services. Again, you can continue to introduce yourself in the chat. It helps us know who is here today. And if you're having any technical issues, you can continue to put that in the chat as well. So my name is Tracy Summer. I'm going to be helping to facilitate today's webinar. And as I mentioned, it's hosted by Max. Max, if you are not already familiar, is the Maryland Addiction Consultation Service. We provide support to prescribers in their practices across the state with questions about addressing the needs of your patients with any substance use disorder or questions about pain management. So we have a phone consultation line for clinical questions. You can also call in if you are looking for resource information. We have our tele-echo clinics, our technical assistance, as well as our Max for Moms, which supports providers treating patients who are pregnant or in the postpartum period as well, with questions about addiction treatment or questions about pain management. So Marcielle is on our team, and thank you, Marcielle, for putting our information into the chat. You can reach out to us anytime for support. Before we dive in, I'm going to quickly go over some housekeeping items in the process to earn credit for today. You can use the chat throughout today's webinar for questions, and there will be time at the end for questions. A copy of today's slides and a recording is going to be uploaded to our website within 1 week. The credit process. To get credit for today's training, you must be online for the full duration of today's webinar, and you must complete the evaluation survey within 7 days from today. Immediately following today's webinar, you'll be able to log into your Oasis portal to access that survey, and then you'll be able to download your CME or your CEU certificate immediately from Oasis. I'm now happy to introduce our presenter for today. So today we have with us Dr. Eric Weintraub. He is our medical director and a consultant for Max. Dr. Weintraub is a professor in psychiatry and in the Department of Psychiatry. He is board certified in general psychiatry and has an added qualification in addiction psychiatry. He's an expert in the treatment of opioid dependence for medications for opioid use disorder. And he has developed several innovative programs in providing treatment to underserved areas by telemedicine. So thank you so much, Dr. Weintraub, for being here today and taking time. I can now pass it on to you.
Thanks, Tracy. And thanks everybody for coming. I want to really excited to talk about this topic. It's something I've been an area I've been working in for over 10 years now, and I've really seen how telemedicine can help increase access to care for underserved individuals. I just want to make sure, Tracy, that things are going up as they should. So we're looking at the objective slide now.
Yep.
So I want to cover several objectives, factors that led to the expansion of the delivery of MOUD via telemedicine, really due to COVID. And we'll talk about this later, a little later. Things really exploded around 2020, where this is now a commonplace way of treating patients. We're going to talk about several different tele-MOUD programs that have been developed, some here by our team, but also some other ones from around the country, and just describe some factors that impact the effective implementation of the tele-MOUD in underserved rural areas, including carceral settings. But first, I'd like to go a little bit over, get an update on kind of where we are with the opioid epidemic, talk a little bit about MOUD, and we'll also discuss the current regulations for telemedicine, prescribing of buprenorphine and other controlled substances, and then we'll dive into more of the individual implementation projects and programs that have been developed. So, as all of you know, and you wouldn't be here if you didn't know this, we are in the midst of an opioid epidemic. We've lost over 1 million individuals since 1999. Most of these, over approximately 70% of overdose deaths are directly related to opioids. We saw a peak in overdose deaths in 2022 and the height of COVID, where we saw over 110,000 people die in 1 year. Over the last couple of years, we've seen some significant decrease in of people that have died, which is a really positive thing. We're trying to understand why that is, and there's a few theories. One is that there's been a decrease in availability of fentanyl due to some issues that are happening over in China, where the precursors are developed. And also, there's more availability of naloxone, MOUD treatment. But whatever the case, we're seeing a significant decrease, although there's still way too many deaths that are occurring. And you can see even as of August 2025, there looks like there's going to be another significant increase for this calendar, for the last calendar year. Um, Next slide. I want to just show you real quickly how this reflects in overdose deaths in Maryland. You can see that things peaked, that the rate of increase peaked in 2016, which was around when fentanyl came onto the scene. But you can see over the last 2 years, we've seen, again, significant decreases in deaths in Maryland as well. And this actually reflects also in Baltimore overdose deaths. We can see in 2025, deaths have decreased by almost half, not quite, since 2000, the peak in 2023. So we're heading in the right direction. And again, it's unclear whether it has to do with what's exactly in the drugs that people are using, or whether it's some of the interventions we're using, and it's probably some combination of both. Just as an update, medications for opioid use disorder are a combination of medications with counseling, behavioral therapies to treat substance use disorders. So we have medications for a variety of different substances, but we're going to focus on those for opioid use disorder. And there's 3 FDA medications approved. One is methadone, the other is buprenorphine, and the third is injectable naltrexone or Vivitrol. What MOD is a critical component of treating medications for opioid use disorder are a critical component of treating opioid use disorder. It's not the only thing that people need, but we know that when people have been using opioids and other drugs for a long period of time, it disrupts their brain chemistry. And using medications like buprenorphine and methadone can help stabilize that chemistry so people don't have to suffer from withdrawal and cravings and are able to focus on other aspects of treatment and recovery. We know that there's been numerous studies. Methadone's been studied very carefully since the 1970s, buprenorphine more since the late 1990s, but we know these medications significantly increase retention in treatment. They decrease illicit opioid use. They decrease the rate of overdoses by 50 to 80%. So they're protective from people and they help keep people alive. Improves social functioning, and when people aren't chasing drugs, they're able to function better socially. We know that it decreases the transmission of infectious diseases and also decreases criminal activity. Here's a study that was done in 2018 that was a review of the literature, and it demonstrated that individuals on medications for opioid use disorder demonstrated much lower rates of all cause and overdose mortality. So people that were not receiving MOUD were 2.5 times likely to die at 1 year and 8 times more likely to overdose at 1 year. Unfortunately, there's a lot of stigma attached to the use of MOUD and these medications like methadone and buprenorphine. I'm not going to go into a lot of that here, but you hear it a lot. You're just addicted to another drug. But these medications are recommended for treatment by every major health organization in the world. And even in the United States, this is not a political issue. Both the recent Democratic and Republican administrations and including the current one, have really pushed strongly to increase access to treatment with MOUD. So it's really not an argument about whether this is an effective evidence-based medication, but sometimes people are not prescribed it because of stigma and sort of individual treatment organizations' views about using methadone and buprenorphine. So as a result, only a small percentage of Americans with OUD who could benefit from medications for opioid use disorder are receiving it. So that's really a sad take on what's going on in our country when we have this really effective evidence-based treatment and only a small percentage of people receive it. So some of the things that we want to focus on here and why telemedicine can be helpful in helping increase access is these are sort of things that have been, these next 4 points are, and you can see the three references in the bottom from ASAM and some other articles that have been written. But initiation of medication treatment should not be delayed while completing long initial assessments and intakes. The goal of treatment is to get people on these medicines as quickly as possible so they don't continue to use medic illicit opioids like fentanyl, which could lead to overdose. Again, medication therapy should not be contingent upon participation in behavioral therapy. It should be offered, but some people are not ready to accept all types of behavioral therapy that some treatment programs mandate. And it's really critical to get people on these medicines to stabilize them and help protect them from overdose. It's been studied, and again, you can get these references both office-based and home buprenorphine induction are safe and effective. I would say over the last 5 to 7 years, we've really gone more to uh, home buprenorphine induction versus office-based. And there's a variety of reasons for that. One is just it's easier for the patients, it meets them where they are, but there's also been some complications due to the way fentanyl is metabolized in starting buprenorphine because it can cause precipitated withdrawal. So we found that for many people, it's safer for them to actually start this at home. Patients seeking addiction treatment, as you can see, are much more likely to be engaged if they are seen on the same day compared to waiting 2+ days. We learned this, and I learned this a long time ago with our methadone program. We used to give people appointments. Sometimes it would be several days away. And when you think about somebody that's addicted to opioids that may be using 6, 7, 8 times a day, the odds of them being able to get to a place on time 3 days later is just very unlikely. So we just started to go into more walk-ins and trying to get people engaged and started in treatment. So they'd be more likely to not only engage, but adhere and be retained in treatment. So what are some of the barriers in receiving treatment? Well, only 76 of patients with any SUD received well, actually, that's 24% of patients with any SOD received treatment in 2022. So the majority did not. Only 18% of patients with opioid use disorder received medicines in 2022. That actually went up to about 25% in 2023, but still, three-quarters of individuals with opioid use disorder do not receive treatment with this gold standard evidence-based with gold standard evidence-based medications. So why is that? So for some, it's on an individual level. Some people don't want to be in treatment, don't want to be on medicines. There are gaps in knowing where to go for treatment. There's frequently difficulty accessing care because certain areas don't have availability of opioid treatment or methadone programs or buprenorphine programs. There can be long wait times. A study from 2019, it's a little bit older, in Pennsylvania showed that patients can wait up to 3 weeks for MOUD treatment. A lot of times there's a long geographical distance from treatment providers. There's also a lot of stigma about being on these medications, about what family members or other people that use drugs that are in abstinence-based treatment programs would think if people were to take buprenorphine or methadone. One of the issues, and we're going to talk about this later, is just availability of medication-based treatment in rural areas. It's important to understand that prior to the overprescribing of pain medications occurred in the late 90s, and the transition of how opioids or illicit opioids are sold from more of a drug, people standing on the corner selling drugs to more of a technological way of being able to order them online. That it Prior to the late 1990s, early 2000s, rural areas really did not have an opioid problem because there just weren't opioids there. Over the last 25 years, that's changed dramatically. And the rate of and I'll talk about this a little bit later, but the rate of opioid use and overdose in rural areas is much greater. And what's happened is, because before 2000 there wasn't much opioid use in rural areas, most of the treatment infrastructure has grown and been expanded in more populous areas. So 90 to 95% of opioid treatment programs are in urban areas. There's many more buprenorphine providers in urban areas as well. So if you can see in 2020, most counties did not have a facility offering any MOUD, and there were individuals that needed treatment. Over 80% were 10 miles from a facility offering MOUD treatment. Now, 10 miles may not sound a lot in an urban area, but we know, and I know from my experience in working in rural areas, that there is no public transportation, there is no Lyft and Uber in many of these counties. So, and many of these individuals don't have cars. So to get 10 miles is a long distance for many people seeking treatment. Again, more population dense areas have higher rates of facilities providing MOUD, and you can see the driving time comparison for treatment providers to get to a treatment provider in an urban versus a rural area. So telehealth is a not only potential, but it's turned out to be a positive solution for the lack of access to treatment for individuals. Prior to COVID, the treatment of individuals with MOUD via telemedicine was rare. We got into the business in 2015, and I'm going to share our experience with that. But when the public health emergency was declared due to COVID, the rules and regulations for prescribing controlled substances via telemedicine changed. What we know is from numerous studies that MOUD provided through telemedicine, the outcomes are similar to traditional care. Programs to provide rapid access to buprenorphine treatment were successfully implemented in several states during the public health emergency with excellent outcomes, and retention in treatment and rate of opioid overdose were improved among Medicare patients who access telemedicine OUD treatment. These are some of the studies that have been that I just mentioned. So if you want to take a picture of this, or I'm sure we'll share the slides, you can actually go through and read up on some of this work that's been done over the last several years. So in review, incorporation of the telehealth technology for MOUD is associated with actually higher patient satisfaction because there's more flexibility in setting up appointments, comparable retention rates to in-person and face-to-face treatment. There's been studies that have demonstrated, and I'll share these with you, an overall reduction in healthcare costs. And it also has increased access to and utilization of buprenorphine. So this is a slide that actually, hopefully you guys can see this, but it gives you a timeline of the telehealth regulation and some of the innovation that has occurred because of the changes in the regulations. So, and I'm going to talk about this in a little more detail. In 2008, the Ryan-Haight Act was passed. And the reason it was passed was up until that time, there was a lot of prescribing going on, what they called rogue online pharmacies, where you could actually just fill out a form and say that you needed pain medicines for your health, and you wouldn't even have to see a doctor, and you would be able to get a prescription through the mail. a young gentleman named Ryan Haight was died of an overdose I think he was from Utah, and as a result, there was a push to regulate how these medications were prescribed via telehealth. Um, so those, and basically, and I'll talk about this, like I said, a little bit later, you had to do an in-person evaluation before you could prescribe via telehealth. Um, we were one of the first groups that sort of studied how this would work through telemedicine. And the reason, and I'll talk to you again about how we got involved in this space, but very few people were doing this because to have to do the in-person evaluation before you could prescribe via telehealth kind of defeated the purpose. You'd have to bring somebody to you and if somebody was in a rural area, that just wasn't going to happen. But in 2020, like I mentioned before, the public health emergency occurred because of COVID, and all the Ryan Haight Act regulations were suspended. And so from 2020 to now, and they remain suspended, there's been a really explosion in the use of telemedicine for MOUD. There's been bridge programs, hybrid programs where people are sometimes seen in person and sometimes through telehealth, and then purely virtual programs. As all of you probably have heard, in January of 2023, the requirement of having an X waiver to prescribe buprenorphine was no longer there, was taken care of. And so, and any person with a DEA license could prescribe buprenorphine. And the waivers that were related to COVID are still in place. And they're actually trying to develop final rules for buprenorphine and that will sort of take a place when the um, temporary public health emergency is ended. Right now, the public health emergency has been extended to through December of 2026. So here are some of the regulatory updates. This is right from the DEA and the Department of Justice. They've proposed special registrations for telemedicine. Remember, these are proposed right now on and remain under public comment and review. And it's really aimed at long-term telemedicine providers, people that do this regularly and consistently. And there are three categories of registration. One is for telemedicine is a telemedicine prescribing registration, which would cover people for having for prescribing for Schedule 3 through 5 medications, which would include buprenorphine, which is a Schedule 3. To be able to prescribe a Schedule 2 substance like amphetamines, you would need an advanced telemedicine prescribing registration, and only certain types of individuals with certain types of, for example, psychiatrists, certain types of pain providers, pediatricians would be allowed to have the advanced telemedicine prescribing registration. And then the telemedicine platform that you're using to connect and do the prescriptions for would have to be registered with the DEA as well. Um, there is a process going on now where they're trying to develop a national PDMP, and when that's developed, you would have to utilize the PDMP before writing a prescription via telehealth. Up until then, we have 3 years to continue to review our state PDMP. If whether they get that done in 3 years and have the national PDMP will remains to be seen. So again, the final buprenorphine rule was postponed to 12/31/2026. And what the final buprenorphine rule is, it's going to change how we do prescribing of buprenorphine, the way it's set up now. So you will be able to start and initiate somebody on buprenorphine via telephone or video virtual video encounter, and can write up to 6 months of buprenorphine. But after 6 months, if this rule takes takes place, you will have to do an in-person or video telemedicine. Oh, you can only do the audio. And after 6 months, either an in-person or video telemedicine encounter is required. You'll be required to check the PDMT of each state, of the state in which the patient is located. And then there's also a provision there for the pharmacist will need to verify the identity of the patient that's picking up the prescription. And that would mean that he would have to have a state issued ID or a bank account with his name on it, or a mortgage, or some type of verification before the pharmacy could fill the prescription. Again, this is proposed and being discussed, but not in place at this time. Again, same thing where I just kind of reiterating what I just had said in the last um, slide. So when we talk about telemedicine models and medications for opioid use, we're predominantly talking about buprenorphine. Methadone has to be prescribed via opioid treatment programs, and since naltrexone and Vivitrol are not controlled substances, they are under different they don't have the same regulations that impact their prescribing. So there's a lot of different models that we see. We've seen a clinic hybrid model uh, come um, come forward, where a lot of times patients are initially seen in person, and then their follow-up, and they have their whole intake done. A lot of their follow-up then can be done through telemedicine. There are now telephone access lines that are being developed across the country, where there's one in Illinois, Rhode Island, for example, where people that are out of treatment can call and get started on buprenorphine and then refer to a community provider. We actually have just started one in Baltimore City that's being funded by opioid restitution funds. There's a bridge clinic model, which is again another different virtual model where people are actually seen virtually initially and followed until they can be connected. And a lot of times this is through more of a virtual video platform, and then they're referred to community treatment. These clinics are sometimes strictly virtual. A lot of times they may, emergency departments start bridge clinic programs where people will come into a emergency room and they have an opioid use disorder. They're started on buprenorphine. They can be followed up by the ED docs via telemedicine until they're connected to community treatment. There's mobile telehealth programs where, uh, and we have developed one of those in Caroline County, where individuals can work with programs in rural areas and who may have counselors and peers, but not a prescriber. And they actually work through a mobile van that goes out and meets people where they are. We've also been able to develop a jail-based telemedicine program to provide MOUD treatment for individuals in more rural jail settings. And then there's community-based treatment. What I mean by community-based treatment is just patient to provider with no clinic or anybody else in between. So it's almost like it is a strictly outpatient, provider to patient treatment model. So those are some of the models that I'm aware of that are being utilized at this time. So just real quickly, I'm going to go through a couple models, and one is the bridge clinic model. So this is a way of sort of filling in gaps for patients. It provides rapidly accessible short-term service where practitioners can prescribe buprenorphine as a bridge to community-based treatment. So we're trying to find somebody that, for example, somebody just got released from jail, either was on MOUD treatment and wasn't, back in the communities, worried about relapsing. He calls the program and wants to get started on buprenorphine right away. So these are services that are provided without an initial in-person exam, and bridge clinic models have been shown to be effective and accepted by patients. And generally, like I said before, you can have a purely virtual model where somebody calls a number, and I'll kind of go through how that may work, versus somebody being seen in an emergency department, started and then followed up um, via outpatient virtual health until they can connect. So there's a gentleman, Michael Lynch, who's a colleague and collaborator who has set up a really amazing program in Pittsburgh, University of Pittsburgh um, clinic that provides bridge treatment for individuals all around Pennsylvania. So the way he has set it up, he created an Epic schedule with a template within his EHR, and they schedule real-time visits as opposed to on demand. Most are scheduled though within 2 hours of the initial contact. So you call, you get an appointment within 2 hours. You're coordinated with their central registration and scheduling professionals. And with his program, they're scheduled for 20-minute time slots with a physician or a nurse practitioner. It could be a PA as well. And then, part of the process would be you would verify their identity, register, check the PDMP, um, and do EHR coordination and demographics. And if necessarily, if you were to determine the patient needed a prescription, you would coordinate with the pharmacy if needed. And I'm going to talk to you about some of the issues that come up with pharmacies when you're doing telemedicine. So this is and he was shared his slides with me, next 2 or 3 slides, but these are based on a study he did, which is cited on the third slide that I'm going to present. So they did over 20,000 patient encounters from April to February of 2025, saw 7,000 over close to 8,000 unique patients. Generally, a lot of Medicaid patients were the predominant people that they saw, and 95% were audio or telephone only visits. I think I want to go, no, here. Yeah. So what you can see is, I think this was really an interesting result of the slide. They looked at actually costs, um, 30 days pre-bridge clinic to bridge clinic visit. And you could see the changes that happened over time. And what you saw was there was a really increase in outpatient behavioral health treatment and a decrease in acute care utilization, which is kind of what we're striving for. So they were able to keep people out of the ED and get them into treatment with outpatient clinics. So in summary, you saw 93, over a 90% percent rate of individuals filling a buprenorphine prescription with 1 month that were seen by the bridge clinic provider. You saw almost a 20% reduction in ED visits among telemedicine bridge clinic patients. And there was a decrease in the overall cost of care for these individuals. This is like an example of a program that really increased access, increased at least early retention, and then seemed to demonstrate a decrease in cost. Now, the issue with a lot of these studies are they're sort of acute and look at short-term outcomes. So we really need to do more studies to determine if these programs continue to work long term and what we can do to increase retention long term. So just I want to throw this out here just for individuals that are thinking of doing this kind of work. What kind of things do you need to be thinking about with your clinical workflow? So I think, first of all, you guys just determine what kind of model that you're going to be looking for. You're going to be working within a pre-existing treatment program, or you're going to have a hybrid model, or are you going to be looking at doing sort of a bridge temporary treatment program and having the infrastructure to refer people for follow-up community care? Or are you going to just be talking to patients one-on-one in their homes and prescribing buprenorphine? You want to make sure you have the appropriate technology infrastructure, the video platform, EHR, compliant EHR, and make sure that which is HIPAA compliant. You want to make sure you're able to conduct patient assessments for OUD and withdrawal via telehealth. You need to check the PDMP before initiating any kind of controlled substance prescribing that's mandated. You want to coordinate MOUD prescribing with pharmacies. One thing that we found out is that if a pharmacist sees that your DEA license address is not close to where the patient is or where the pharmacy is, they will have questions about what you're doing and why you're writing a prescription to somebody so far away. What we've done is we've kind of identified pharmacies that are going to be close to the patients we're working with, called them and developed relationships so they know who we are and what we're doing. I think it's really important to develop SOPs addressing screening, assessment, follow-up, referral for counseling. Not everybody has to go to counseling, but you should have a way of getting people to counseling if they want it. And also to make sure you know how to, that you're able to do drug testing, which I think is an important part of treating people with buprenorphine. And then if you have the time to do quality assurance, you want to look at initiation rates, how many people are getting started and filling their prescriptions. Are you able to retain these people and in treatment? What are your overdose rates looking like? And even if you have time, you could look at patient satisfaction with how you're doing your outpatient telemedicine work. So I'm going to go back to, real quickly to talk about some rural data, and then from there talk about a couple programs we have put together to work with individuals with opioid use disorder in rural underserved areas. So as I said before, since 2000, we've seen a really rapid increase in um, opioid use and opioid overdose deaths in rural areas to the point where they're very similar. It says surpass there, but they're really similar to those of urban areas right now. It's kind of gone back and forth. And most of the treatment that has been set up prior to the 2000s was in urban areas. So, as I mentioned before, 95% of OTPs are in urban areas, and there's just a lack of access to treatment in many rural areas. Here is a map. This is old. It's probably from closer to 2018, but you can see that a lot of the opioid overdose deaths, which were above the national average, occurred in more rural Rust Belt states like Ohio, West Virginia, Kentucky were really hit hard. Um, so again, this is kind of just summarizing with some uh, references below, kind of to talk about the rural opioid problem and why we have tried to set up some telemedicine programs to increase access to buprenorphine and other the gold standard treatment, one of the gold standard treatments. You can see even in Maryland, the healthcare shortages in the dark blue are all in kind of our rural areas. The Eastern Shore is specific, has a lot of healthcare shortages. Southern Maryland and really a large part of Western Maryland, uh, which would make sense. And I know, and again, I don't know how many people here are from around the state, but I know for myself that trying to find counselors in some of these areas has been very challenging for us and nurses as well. So I'm going to talk a little bit about our treatment program, MOUD telemedicine treatment program, how we got started. Like Tracy said at the beginning, I'm at the University of Maryland School of Medicine, and so I work in an academic institution, and what we've done over the course of the years is go right here, is currently this is kind of our current setup. So we're in, I think, nine counties. I don't think Dorchester is actually written here, and we have a variety of different types of programs. We have a mobile treatment program in Kent County and Caroline County. We are in 7 different detention centers. So sorry, and we're also in several outpatient programs in different rural areas. So next slide. Want to go over the Ryan Haight Act again. We talked a little bit about that, but so you can just read through these. But the bottom line was prior to 2020, you had to do an in-person medical evaluation that is conducted with the patient in the physical presence of the practitioner. That was kind of what was creating an obstacle, really a large barrier for using buprenorphine for telemedicine. So we got started in 2015, and we were kind of unaware, a little bit naive about the Ryan Haight Act. We got a call from somebody at the Wells House in Hagerstown, Charlie Moonaghan, who was a colleague of ours, had lost his prescriber, and asked if we could do help him out in prescribing buprenorphine because he saw that a lot of his patients were suffering from withdrawal and were unable to stay in treatment if they didn't get medicine. So this is an IOPOP program. Most of the patients had their own housing. They had no medical staff there. So what we decided was we would set up a telemedicine program, and we did not follow strictly the Ryan Haight Act rules. We were doing this through telemedicine. I would have to say we were a little bit unaware and naive, although it kind of caught up to us as we went along. But we found that this was a really reliable way of taking care of patients. People liked it. We were able to work with the staff at the Wells House. We would get urine toxicology screens. It's kind of a captive audience. And we figured out ways where the staff would be able to deliver medications that were picked up from a pharmacy. We did an initial study of the first 177 patients, and retention was actually relatively good. A lot of the people that left for good reasons because they had to get back to their job or their families, not because they were doing poorly, and people were not using drugs while they were there. And then, so we published this, and then we went to the second group. We looked at our first 472 patients, and you can see still doing well, similar to inpatient treatment. What happened next is I did an interview with somebody from Politico, which was a national, they write about different topics, and thought they were going to publish something nice about what we were doing. And I remember somebody called me from the Wells House, Paul, who was my colleague and sort of the coordinator there, and he said, "You got to see this article that they wrote." So this is what they wrote, which shows you how far I mean, the reason I show this is really it demonstrates how far we've come through since I think this was written in like 2018, right before COVID. And at that time, it seemed like we were doing some wild and crazy thing of taking the law into our own hands. But what it demonstrated was that we were not in compliance with Ryan Haight, and that it got back to the dean of the medical school, who was actually pretty reasonable, but I had to meet with the attorneys, and turned out we were actually in some trouble of maybe having to shut down our programs if we couldn't figure out a way to be able to see people individually. But what we did was we were able to work with the DEA and figure out that if we could get our treatment programs registered as a DEA hospital clinic, that we would be able to do this under the Ryan Haight Act. So we were able to do that. And I just want to kind of go through what our model is, which is just the way we have done business, which is it's a very kind of, in some ways, a narrow way of approaching this because we've always worked with other rural treatment centers in an area in need of buprenorphine prescribers. We do not go like home to home with individuals without them being in a program. All the programs we work with now receive DEA certification prior to us working with them. Um, and we have SOPs focusing on clinical communication with these programs. And it's really been helpful to have a program coordinator on the other side that helps kind of keep track of us and our prescribing. And if patients, need a prescription, they'll let us know. So we started working with different programs around the state, including health departments. And I think our next, what I would call innovation was we found that we were working with the Caroline County Health Department, and what we found was that even in working with Denton and the health department there and doing telemedicine, we weren't able to touch and reach a lot of other individuals in the Caroline County catchment area. So there was a HRSA grant, and we kind of just said, "Hey, let's apply for this and see if we can actually get a mobile telemedicine unit." And I have to be honest with you, when we first thought about it, we didn't really know exactly how it would operate. We were thinking we would sort of follow up with people that had overdosed. But as time went on, what we did was we set up clinics in the van in different areas of Caroline County that were considered the hot spots for overdoses. And on the van, we had a full treatment team of a peer recovery specialist who also was very good mechanically and took care of the van. We set up telemedicine clinic there, telemedicine equipment there that was coordinated between our IT and Caroline County's IT. And we also had a nurse and a counselor on the van that provided, excellent care for our patients. And all we did, what we did the prescribing and, some of the motivational interviewing. And so you can see that we were in four different counties, four different towns. We're really not in Ridgely anymore, really just Greensboro, Federalsburg, and we're running two clinics in Denton. And we also expanded into King County, and we're in Chestertown as well. And what we did was we found out that we wrote a paper and published in Jam Open Network that our patients that we saw on this mobile unit did as well as patients in brick and mortar. And this is all well known now, but back then it was kind of sort of emerging data. So you can see some of the data there. I don't think I need to go into too much. And this is the team that we have. And obviously, for any kind of program like this, you need group of people, including our peers. We had researchers, we had our counselors, Carolina County Health Department folks are all there. Real quick, I just want to talk about incarcerated individuals. They have a heightened risk of OUD and overdose. Many of them have SUD diagnoses, and they estimate 15% have OUD. The risk of overdose deaths if people aren't on medications or on release from jail are astronomical because people have no tolerance and the drug supply is so toxic. So people leave, they go back and use drugs and overdose. Very few correctional facilities offer MOUD, as you can see right there. And studies of jails that do offer MUD have been very positive in that they're effective and life-saving. You can see the top study. I can get you the reference on this. That those that received MOUD in New York jails 3 days prior to release had an 80% reduction in overdose mortality. And again, another study that looked at recidivism in Massachusetts. There were two counties adjacent to each other. One one had an MOUD program, the other didn't. And the one that had the program had a 30% decrease in reincarceration of their patients. Our program, we're now in 7 rural detention centers, which is 40% of Maryland's 18 rural jurisdictions. You can see the stars there. Most of them are on the Eastern Shore, although one is in Western Maryland. Since our program started, I guess the first program we rolled out was in Talbot County. We've seen over 1,200 patients. A lot of patients, there's been a fair amount of readmissions, but many of those readmissions are not necessarily people that relapsed. It's as I've learned as I've worked in the carceral setting, it's very easy to get reincarcerated for minor violations of parole, even after 20 or 30 days. And many of the patients, not all that come back, actually seem to be doing quite well and are doing well in treatment. Just real quickly, we've written one paper. We've written actually several papers. This is one paper I'd like to focus on. Allegheny County, we've had a great relationship with their detention center. They have a wonderful warden and nurse that we work with. We looked at the first 117 patients that we saw that we treated there, and we looked at those four things. Did they fill up a bridge prescription within 5 days? And were there any opioid overdoses within 90 days of release? So 68 of the patients received a bridge script at the time of release out of the 117. Some of those patients did not need a bridge prescription because they already had medicines at home, or they had a really quick follow-up appointment with their outpatient provider. Of the 68 patients that we wrote a prescription for, 85% filled the bridge prescription. And then we were able to see that another 60% filled any buprenorphine script within 14 days of release. That was of the total 117 patients. And then we were able to actually work with a medical examiner and track patients, at least through the state of Maryland. If somebody had died of an overdose in West Virginia or Pennsylvania, we wouldn't have that information. But there were no fatal opioid-related overdoses within 90 days of release for the patients, for that first 117 patients, which we're really happy about, because that's kind of why we were there, was trying to help people get on treatment and avoid overdose upon release. I think that's what I have. So I wanted to leave a couple minutes if anybody had a question.
Thank you so much, Dr. Weintraub. We actually do have a question that came into the chat during your presentation. Any criteria to address which patients could be considered for telemedicine in terms of risk of relapse and stability?
I think pretty much all patients can be considered for telemedicine I mean, again, it depends a little bit on the model. If you're initiating somebody, uh, I I think it's important to have access for them to be able to get urine toxicology screens, and do a full evaluation, and whether you can do that face to face. So like again, in my model, or the model that we've been using here, we're working with other treatment providers that are able to do those things. So you would have to have, I think, there's nothing in itself about telemedicine or face to face that makes a difference about who that I can think about any risk factors that would make one person. Um, well, I mean, so let me just take a step back. I think there has to be a screening process. If somebody's acutely suicidal, or is having some kind of acute medical issue, then I wouldn't prescribe through telemedicine. If somebody called and said, I'm having, severe chest pain. So I think those people need to get more acute care. If somebody was suicidal or having thoughts of hurting somebody else, then they would need to be psychiatrically screened. But if it's just strictly somebody that's medically and psychiatrically stable that needs medications for opioid use disorder, I can't think of anything, including comorbid substance use, that would make it somebody better for in-person or telemedicine induction. I don't know if that
Thank
answers.
you. I haven't seen any other questions come into the chat, but again, for folks, if you do have any questions, you're welcome to put them in the chat, or if you would like to unmute, you can unmute as well. So we do still have a few minutes for questions. In the meantime, I can take this time to just again go over some housekeeping items and the process for earning credit for today's training. We actually do have another question that came into the chat, so I don't want to take up too much time. But this same provider said, great, to your first answer. Great. And how about if patients are pregnant and actively using substances?
Yeah, they're actually really need to be put on MOUD treatment as well. So obviously they need to see an OB. But I've actually treated several pregnant patients on the mobile unit that we have. And the assumption is that they're getting treatment, but with a OB or midwife, but that would not be a reason to withhold medications for opioid use disorder because that's the sort of gold standard for people for women that are pregnant. And we can share some studies with you. And we actually have, I don't know if you want to talk for about Max for Moms, Tracy, that we have a special program that actually addresses that specific issue.
Yes. Yes, thank you so much for bringing that up. I'm happy to be sure for you for this provider, as well as for everyone on. I'm happy to be sure that you have information on our Max for Moms program. It's another kind of arm and branch to our overall Max program, but really targets, and we have a specialized team of consultants with addressing patients who are pregnant or in the postpartum period, again, with questions about addiction treatment or pain management. So we have some consultant specialists who are practicing OBs and are certainly experts in the field. So we can also be sure that you have our materials for our moms program. We actually have an upcoming webinar with one of our consultants, Dr. Katie Mark, on perinatal and withdrawal management. That's coming up at the end of May. And thank you so much. Someone also commented support for the moms program, Carla. Thank you so much. We are happy to help. It's our same phone number to call for our moms program. I don't see any other questions in the chat at the moment, but again, if you have anything else, please feel free to put it in the chat or you can unmute. Another question that did just come in, so two more that came in. It says, great presentation, Eric. What do you think about telemed programs that allow for unsupervised drug screens, like at home or self-reported results that forego drug screens?
Yeah, that's a great question. I actually believe that your toxicology screens are really and sometimes supervised. Your toxicology screens are an important part of treatment, not as a punitive measure, but just as a mechanism of knowing what's going on with a patient. And I'm not saying I don't think that every time you see a patient, they need a supervised urine, but sometime during the course of the treatment episode, whether it's once every 6 months, once a year, I mean, I think you could think about it in terms of how the patient's doing. But to me, it's no different than getting uh, blood levels of certain medications. And people can say that they're taking the medicine. And so there are two reasons for that. One is, are people getting the appropriate amount of medicine, and are they taking it appropriately? And to be honest with you, I mean, we know that there is some diversion of this medication as well. And you also want to know whether people are taking other substances, in case you decide that in your role as an MOUD prescriber, you're prescribing other medications to maybe treat anxiety, depression, or if you're an internist or family medicine provider, some other medicine for a medical problem. And I think having a supervised urine tox screen is helpful in guiding treatment.
Thank you. Another question that we have, do you consider Sublocade versus Suboxone?
I think injectable, I mean, basically they're the same medication in the sense they have buprenorphine, just a different delivery system. I think a lot of individual will find injectable buprenorphine, whether it's Sublocade or Brixadi, as an option that would be effective for them. And so I always talk about that in my risk benefit discussion. And there's some people that say they don't want a needle, they'll never want one. But I just try to explain what the benefits of having an injection would be and what the downside is. You have to get a shot every month, but you don't have to worry about taking medications every day or losing them. And the fact that buprenorphine in an injectable form gives you a long-lasting high level that doesn't fluctuate over the course of a day, maybe the reason why some people would want to take it. But I think it should be in the risk-benefit discussion when you talk about starting somebody on buprenorphine.
Thank you, Dr. Weintraub. I know that we are at time. So again, if you do have any other questions, you are welcome to contact us at Max. You can call our consultation line, you can send us an email, and we are certainly happy to help. So you will be able to go into your Oasis portal right now, and you'll be able to access your evaluation. And you do need to complete that within 7 days from today in order to access your CME or your CEU certificate. So we can end there. And again, thank you everyone for joining us today, for taking time out of your busy schedules. I know the spring can be full and busy, so I hope everyone has a great rest of your day.